First of all, thanks to the organizer, thanks to Imad for the invitation, and always enjoy coming over here and appreciate the hospitality, and thank you so much. My topic is EUS-guided biliary drainage in malignant obstruction, when and how. These are my disclosures. Malignant biliary obstruction happens with a pancreatic cancer or hepatobiliary cancer. Usually, the first-line therapy for those to relieve the obstruction is ERCP. First ERCP done 1968, and for last almost 4 decades, it's been the first-line therapy. Other options include radiology or surgery, but now EUS has emerged as an other option to deal with this obstruction. And really for all those EUS enthusiasts out there, I don't mean to dampen your enthusiasm about the EUS-guided biliary drainage, but this is the study we did a few years ago and published in 2016 of consecutive 1,000 ERCPs to determine really how often you need a EUS-guided biliary drainage. So in these 1,000 ERCPs, there were 524 native papillas. Ampulla reached in, or papilla reached in 518 patients. Some of those, they were referred from outside failed cases. All those were able to be achieved by successful cannulation. Bottom line is, in those 524 native papilla cases, only 3 cases really required EUS-guided biliary drainage. So the indications were different. When we're talking about malignant biliary obstruction, it may be a little bit different rate where we require that drainage, but it is not quite often required, and there are only some indications for EUS-guided biliary drainage. It should not replace good ERCP technique. With that, even now, failed ERCP, if ampulla is accessible, then you should, like the ERCP, first you should try regular way. If ERCP fails and then ampulla is accessible, then we can go with the EUS, and there are different ways to access the biliary system with the EUS. EUS provides us alternative points of access to the biliary system. Those could be through the liver or could be through the bile duct. If it is through the liver, it is usually transgastric, except in certain instances in altered anatomy, but mostly it's transgastric. And in transgastric approach, you can put a stent from the stomach into the left hepatic system, what we call a hepaticogastric stent, or we can do a rendezvous technique, get the wire from the left lobe of the liver through the hilar area into the bile duct and into the duodenum, and then put a stent through that. The other approach is transduodenal approach. Similar way, it could be a transluminal stent placement, or it could be a rendezvous technique. You stick the bile duct from the duodenum, get the wire through the papilla into the duodenum, and then access the bile duct alongside that wire, or you can grab the wire and pull that through the scope after exchanging with the ERCP scope, and then perform the ERCP. Multiple trials on EUS-guided biliary drainage. There have been 3 randomized trials previously published, and multiple retrospective studies all basically have shown that EUS-guided biliary drainage has a great technical success, great clinical success, likely low rate of interventions, but it is not without adverse events. Like, adverse events do happen up to more than 50% of the cases. There's no difference in technical and clinical success when you compare to the ERCP, and overall adverse events possibly the same. There is a less rate of pancreatitis in EUS-guided, and maybe likely less rate of interventions. This is the trial I really want to mention about, recently published, primary EUS versus ERCP for unresectable distal malignant obstruction. Mostly led from Hong Kong by Dr. Tio's group, some centers in Thailand, mostly centers were in Europe. They randomized the patients with the distal malignant biliary obstruction to either EUS-guided to begin with or ERCP guided. If you look at the number of the patients, pretty much similar, 79, 76. The technical success rate was much higher in EUS group as compared to the ERCP group. So in EUS group, the technical success was close to 96%, but in ERCP group, only 76% of the patients, they were able to perform direct ERCP, and procedural time was also less in EUS as compared to ERCP. If you look at the cumulative survival, and their primary endpoint was the stent patency at 1 year, they were not different in these two groups. So what they concluded is both procedures is an option as a primary biliary drainage modality for these kind of patients. And in certain instances, it may be advisable to just proceed with the EUS biliary drainage. I want to really commend the authors on putting up this trial, which was prospective, which was randomized. There was standardization of the stent. For the EUS-guided, it was lumen opposing metal stent, which is the Axios. In all patients, that stent was used. And for ERCP, it was partially covered wall flex stent. So all that good, but I do have some reservations about the trial as well. 76% ERCP success. That really looks low. Is it really an underperformance of ERCP? Not sure about that, because these were all high referral-based centers. In those 76 patients, there was a failure of ERCP in 18 patients. One, because of perforation happened with the ERCP scope. 7, they could not reach the papilla. In other 10, they just could not cannulate the papilla. And so even if you exclude all those which where there was a duodenal stricture and the perforation, but there were 10 patients, that still comes out to be ERCP cannulation rate of 85% or so, which kind of indicates underperformance. So based on that, even though it shows in favor of EUS, but I'm not certain it can replace a good ERCP technique. How do we do a transgastric approach? If we end up doing a EUS-guided, you access the left lobe of the liver with the wide 19-gauge needle, put a contrast, put the wire through that, get that wire through the left lobe of the liver, through the hilum, bile duct, and into the jejunum. And then after that, if you look here, you can see the bile duct stricture right there with the arrow points, and then you can place antegrade stent. Now we have these lumen opposing metal stents, which are short dumbbell-shaped stents, come in different sizes. They allow the apposition of walls between two cavities, and here either between the stomach and duodenum to the bile duct wall, but mostly when we use these Axios, we are using it from the duodenum and going into the bile duct. They are approved only basically for pseudocyst drainages, but we use those for many different reasons, and one of those is bile duct drainage. If you look at this case, you can see that there was a very tight stricture in the duodenum. In this case, the bile duct is being accessed with the 19-gauge needle from the duodenal bulb. Contrast is injected, and then after that, that needle is removed, and then we use the Axios stent or lumen opposing metal stent With that, the distal tip has a cautery, and when you do a indentation on that of the bile duct, use the cautery, push that into the bile duct, and then deploy the distal dumbbell first and then the proximal. In this case, you would see that I put a dye into the bile duct. Nowadays, I'm not doing that. If I use it without injection of the contrast sometimes can be problematic with the EUS imaging. But after that, dilated that stent and then put a double pigtail plastic through that stent. And other case of Whipple, post-Whipple for cancer. A few months later, patient developed jaundice, and then did an endoscopy, got to the area of anastomosis, and there is a big mass recurrence, which could not cannulate with the actual enteroscope, which I used actually pediatric colonoscope. So what decided to see if I can get a EUS scope, was able to get the EUS scope straight there to the anastomosis site, and was able to put an axial stent or a lumen opposing stent in this case as well. Other thing, we talk about the gallbladder drainage. Majority of the time it's acute cholecystitis, maybe for some other reason. There are two reasons which can, in case of cancer obstruction, it can happen. One is the mass itself obstructing, where it's involving the cystic duct. And in those cases, if they are not a surgical candidate, we can do a transluminal gallbladder drainage. Second thing, sometimes what happens is when you put a biliary metal stent, or for that matter, plastic stent as well, sometimes that can cause a blockage of the cystic duct and patient can develop a cholecystitis. In this case, this study, also from Dr. Tia's group, if you look at it, they compared the EUS-guided gallbladder drainage with the PTC or PTGBD. You can see that with regard to adverse events, reintervention rate, unplanned admissions, everything favored EUS-guided biliary drainage, gallbladder drainage. The traditional way to drain is you access it either from the stomach or from the duodenal bulb, put a wire down there with the 19 gauge needle, and then dilate the tract and then put a tubular metal stent in there. But now we can do same thing with the lumen opposing metal stents. Access, many times I just don't put a contrast there into the gallbladder anymore, just use the straight lumen opposing metal stent, just deploy the distal end, and then you can deploy the proximal end into the either the duodenum or stomach. The only thing you have to be careful about is like if you're accessing it from the stomach, be mindful that you don't block the pylorus area, be there away from it for 1 or 2 centimeters away. So take home message, EUS-guided biliary drainage, it has passed initial hiccups, it has passed initial stage, and now has occupied a place in endoscopy as feet, as it provides alternative points of access to the biliary system. So we have another option, especially if we are not able to access the papilla and or not able to do ERCP for any reason, we have this option available. Keep in mind, it does need expertise. We still need to work on dedicated accessories and standardization of the procedure. It is becoming more widely available, but still not available everywhere, and it does have adverse events. Need to be careful about that. It is to me, it is an excellent alternative and complementary to the ERCP, but still likely not the first line. Thank you.